So, fine. Alitza, I think maybe joining later from the academy. So we'll just go ahead and start. Welcome all to this fourth in the series of dermatopathology quiz-based lectures on behalf of SIG Dermatopathology, IADVL Academy, and Dermatopathology Society of India. First, would like to thank Lodama for supporting this, and also thank DSI and the IADVL Academy for giving us this opportunity to discuss dermatopathology, which is a very niche subject, of course. Now, today we have discussed basic dermatopathology in the first lecture. We have discussed evaluation stepwise, evaluation of the slide. We have discussed spongiotic and psoriasiform dermatosis in the earlier lecture. And this one, we're going to discuss interface dermatosis, both vacuolar and lichenoid. So before we do that, some ground rules for Kahoot. So a lot of you are participating in the quiz. And if you're not, so savvy about the quiz, please still do participate because it makes it more fun. Because most of the things we're going to discuss today are in the form of a quiz. So it will make it very interactive and it will help you learn as well. So to participate in Kahoot, you need to have one device for listening to this lecture on Zoom, and another device, preferably, where you can log into Kahoot on this website, kahoot.it, or you can download the Kahoot app if you've not already done it. And the game pin was displayed earlier. It is in the chat box again. Tech team, can you please keep posting the game pin in the chat box for those of the attendees who are joining late. So log in with their full names, including surname for identification. The time for each question may vary based on the difficulty of the question, and once attempted, we cannot go back to the previous question. Each question is marked out of 1,000 points. The maximum points are scored by the fastest correct answer. So say a question is allotted 20 seconds, the person who answers at the 5th second will score more than the person who answers at the 10th second. And if you answer two answers, if you get two questions in a row correct, you get a streak bonus, which means you get 100 points extra, up to a maximum of 500 points. And then if you get a wrong answer, you won't get any extra points. Again, your streak bonus will go back to 0. And then if you get 2 in a row correct, then you get 100 points more again. Okay. And so tip is, if you do not know the answer at all and have decided to guess fast. Okay. So we basically have heard these terms interface, lichenoid, and vacuolar in a number of books and lectures, and all these are confusing terms, isn't it? What is interface? What is lichenoid? What is vacuolar? And is it very important really to make a distinction between these entities? But first of all, let us learn what is interface. Interface, by definition, is the surface forming a common boundary between two bodies, spaces, or phases. So with regards to the skin, interface basically refers to the surface or the boundary between the epidermis and the dermis. And this extends down the hair follicle. So this entire border is called the interface. Okay. So any dermatosis affecting this border technically is an interface dermatitis. But it's not always the case. We'll come down to the definition a bit later. So interface dermatoses are traditionally classified into lichenoid and vacuolar. Now, some textbooks use the term lichenoid to encompass even vacuolar interface dermatitis, but that is not technically correct. Okay. So interface dermatitis are either lichenoid or vacuolar. I'll come back to that in a second. So first, lichenoid. Lichenoid refers to inflammatory dermatosis that are characterized by a band-like lymphohistiocytic infiltrate in the upper dermis, hugging and often obscuring the dermo-epidermal interface. So the prototype for this is lichen planus. You can see a band-like interface dermatitis, band-like lichenoid infiltrate that is hugging the interface. Okay, it's not obscuring it. You can still see the interface. The interface is still visible. Now, in this example, which is pleva, you see that the interface is obscured. The infiltrate has gone up into the epidermis. In contrast, in lichen planus, the infiltrate is hugging but not crossing the interface. In the other example, pleva, the infiltrate is crossed into the epidermis. Okay, so both are lichenoid dermatosis. In one, it is hugging, and the other one, it is obscuring the interface. So this brings us to Kahoot quiz number 1. Okay. So let's see how many people are there. There are 28 people. I'll give like a minute more for people who have joined late. So that's a game pin. If you want to join still, it's 350-2404. You can also scan the QR code that is visible here if it's scannable on your mobile to get into the quiz. So the 27 people will give 10 more seconds before we start the quiz. If you've joined late and you want to continue the quiz, even if you missed one question, it doesn't matter. You can still take part in the quiz. Whether you win or not does not matter really. Well, of course, it's good to win, but it still makes the lecture interesting. So 29 people, 30. Okay, still people joining in, 31. Let us just wait for 10 more seconds, 32. Okay. So while other people are joining, let us start the quiz. So 33 people who have joined. Okay. So the first question coming up. The pin will still be visible in one at the bottom. Okay, 1 of 16, which is true. Okay. Testing your basic knowledge. Vacuolar degeneration is not usually seen in lichen planus. Second option, vacuolar degeneration of keratinocytes results in colloid bodies. 3, immunohistochemically, colloid bodies resemble cutaneous amyloid. Or 4, all the above. Right. So a majority of you have ticked all the above. In fact, vacuolar degeneration is also seen in lichen planus. Though it is technically a lichenoid interface dermatosis, we still see vacuolar degeneration. I'll explain that in a second. Vacuolar degeneration is not what results in colloid bodies. I'll explain that also in a few slides. But yes, immunohistochemically, colloid bodies resemble cutaneous amyloid. In fact, if you look at the pathogens of cutaneous amyloid, it is the epidermal keratin that once degenerate drops down into the papillary dermis, and this is what forms amyloid. And amyloid, if you look at it on H&E, it looks similar to colloid bodies. Okay. So colloid bodies and amyloid, basically colloid bodies are what eventually result in amyloid if the colloid bodies are not cleared up. And that is the basic pathogenesis. Though lichen amyloidosis is not interface dermatosis per se, because of chronic scratching in lichen amyloidosis or cutaneous amyloid, what happens is that the epidermal keratinocytes become apoptotic. And these apoptotic keratinocytes, they drop down to the dermis and they form colloid bodies, and these colloid bodies join together, forming amyloid. And this is what is believed to be the pathogenesis of cutaneous amyloid. Okay, so after the first question, so SJ is leading, followed by Gamana and Namiti. Now, SJ and Gamana, if those are your full names, that's okay. And CTD is 0. So there are only 4 winners, 4 people who got the correct answer. If you want to win any prizes, then you need to enter your full name. Okay. Okay. So this that's quiz number 1. So vacuolar degeneration basically implies hydropic or ballooning or liquefied degeneration, where the keratinocytes appear swollen due to intracellular edema. And this is because of the inflammation. And this leads to the formation of intracytoplasmic vacuoles. In vacuolar degeneration, the nuclei then appear pycnotic, shrunken, or hypochromatic, and eventually undergo karyexis, which is nuclear fragmentation and disintegration. And this is the typical example of vacuolar interface dermatitis. Okay, you see a vacuole and the nucleus has become pycnotic. You see here the nucleus become dark and condensed around the vacuole, and this is vacuolar degeneration. Okay, now sorry, have I yeah, okay. So what are extracellular vacuoles? Now we have seen intracellular vacuoles. What are extracellular vacuoles? Now these are different from intracellular vacuoles. Now, when the vacuolar degeneration becomes confluent, these cells all coalesce together. So these vacuoles coalesce together, causing, in this case, suprabasal vacuoles. So these are not technically intracellular, the cells have all become degenerate and the vacuoles have joined together. Okay, this is a suprabasal extracellular vacuole. In this example, lichen planus, you're seeing the basement membrane itself have become degenerate. So there's some vacuoles within the basement membrane. You're not seeing any nuclei. There's some vacuoles within the basement membrane. There's some vacuoles even underneath the basement membrane. So you're seeing intrabasal and also infrabasal vacuoles. In this example of lichen sclerosis, because of the sclerotic papillary dermis, during processing, the epidermis separates from the thick dermis, and this leads to an artifactual cleft. And you can see the basement membrane here, and the cleft is underneath it. So this is an infrabasal vacuole. So extracellular vacuoles are associated with, but are not true vacuolar degeneration. They're not true intracytoplasmic vacuoles always. So they can be suprabasal, within the basement membrane, or infrabasal. Okay. So this brings us to Kahoot quiz number 2. So 2 out of 16. So be ready for the next quiz. For those of you who joined late, if you want to still join, the game pin is 3502404. You can still join in. Okay. So next question, 2 of 16, which is true once again. Your options are: lymphocytes are usually seen within max Joseph space. Max Joseph space contains serum. Max Joseph space is pathognomonic of lichen planus, or none of the above. Excellent. Majority of you have got it right. Lymphocytes, now max Joseph space are artifactual spaces. Okay. They are basically processing artifacts, like in the case I've showed you, right? Like the extracellular vacuoles. So the vacuoles within the basement membrane are caused by basement membrane disintegration, but that also is an artifact to some extent, because during processing, due to the pressure of cutting, the vacuoles become exaggerated. Okay. So you don't see any inflammatory cells or serum within these max Joseph spaces. And max Joseph space, I showed you in the lichen sclerosis case, is not pathognomonic of lichen planus, can be seen in any interface dermatosis. So the answer is none of the above. So let's see after the second round, second question, Shreya is leading, followed by Namita, Shubham, PM, and Abhi. PM, you need to get your name correct if you want the prize. Okay. So going back to the presentation. Quiz number 3, actually, we're moving on to quiz number 3. So yes, let's move on to quiz number 3. So the next question, 3 out of 16. Basement membrane vacuation can also be seen in immunobullous disease like bullous pemphigoid. Why is it not classified as an interface dermatosis? Okay, basement membrane vacuation also seen in BP. Why is it not classified as an interface dermatosis? Is it because of presence of serum and inflammation within the bullae? Absence of basal epidermal cell damage in BP? Or absence of colloid bodies in immunobullous diseases, or both 1 and 2? Right. The answer is given by the majority. 21 people have got the correct answer. So in an interface dermatosis, there has to be epidermal basal cell damage, and that is a sine qua non of calling something an interface dermatosis. So I told you in the beginning, everything that affects the interface is not an interface dermatosis. It doesn't not an interface dermatitis. Okay. So yes, presence of serum inflammation within the bulla of immunobullous disorder is there, but then you have bullous lichen planus where you also have serum and inflammation. Okay. Or you have bullous lichen sclerosis where you also have serum and inflammation. That is due to so much inflammation there. There is serum accumulation and inflammation within the bulla. Now, max Joseph spaces do not present as bullae clinically. But when you have clinical bullae in the form of in lichen planus or in lichen sclerosis, for example, or even lupus, you do have serum and inflammation within the bullae. Colloid bodies do not always need to be present. Even in interface dermatosis, even in lichenoid dermatosis, you may not always see colloid bodies, and that is not necessary, and that is not the reason we are calling we are not calling immunobullous diseases as interface dermatosis. Keep posting your questions in the chat boxes, by the way, and chat box, by the way. And if when we have time at the end, we'll discuss your questions. Okay. So let's see how the leaderboard is looking like at the end of 4 questions, I think. 3 questions, sorry. Shreya is leading still, followed by Jalina, USS, PM. You need to get your names right, as I said. Okay. So quiz number 4 will come to later. So an easy way to remember interface dermatosis, whether they're lichenoid or vacuolar, is that lichenoid dermatosis are generally cell-rich. Vacuolar interface dermatosis are generally cell-poor. We'll come to this in a second. So the prototype of lichenoid dermatosis are lichen planus, lichen nidus, lichen striatus, and pleva. The prototype of vacuolar interface dermatosis, where you have predominant vacuoles, are erythema multiforme, lupus, dermatomyositis, LS, poikilodermas. So why are we calling these? I told you the lichen planus also has vacuoles. So why are we calling only erythema multiforme, etc. vacuolar? Why are we calling lichen planus as lichenoid? I told you that one way these are differentiated is whether they are cell-rich or cell-poor. But there is a pathogenic mechanism why they are differentiated. I'll come to that in a second. We'll understand these why they've put into these categories as we go on. So interface dermatosis by definition is inflammatory dermatosis primarily affecting the interface elements along the dermal-epidermal junction, resulting in epidermal basal cell damage. So epidermal basal cell damage is essential. And that is why bullous pemphigoid, though it affects the interface, is not an interface dermatosis. Lichenoid interface dermatosis is where interface dermatitis with intense inflammation overruns the vacuolar interface change. Okay, so there's interface dermatitis with intense inflammation. Whereas in vacuolar interface dermatitis, there is paucicellular interface dermatitis, where the vacuolar interface change is prominent because the cells don't overrun the vacuolar interface change. Okay, I hope it makes sense. I come back when I show you the pictures, you'll probably understand. Now, not only is the intensity of inflammation the distinguishing factor, it's actually the type of basal cell damage that is also a distinguishing factor. So there are two types of basal cell damage or epidermal cell damage. Let us not restrict it to the basal cells. I'll explain why it's not restricted to the basal cells in a second. But the two types of epidermal cell damage. One is vacuolar, which we've discussed already. But the second type, sorry, the number is, it should be number 2. The second type is filamentous. And this is not talked about in dermatology textbooks a lot. In fact, dermatopathology textbooks also don't talk about this a lot. So what is filamentous degeneration? Filamentous degeneration is seen primarily in the lichenoid group of diseases. Visible as shrunken, apoptotic, or dyskeratotic keratinocytes. Now, what is dyskeratotic? Dyskeratotic means a disordered or premature keratinization, also called dysmaturation. And this is visible on H&E as civet bodies or colloid bodies. And these are a result of filamentous degeneration. Now, not all apoptotic keratinocytes. Now, this is an apoptotic keratinocyte, for example. This does not result in a colloid body because this is a result of vacuolar degeneration. If something is a result of filamentous degeneration, which is usually a result of apoptosis. Now, during the process of apoptosis, there is clumping of tonofilaments within the keratinocytes. These tonofilaments and keratin basically clump together, forming these civet bodies, which are eosinophilic, aggregations within the keratinocytes. Now, these may also have vacuoles. Now, some of these vacuoles are because of separation of the cell membrane from surrounding cells. But you may also have intracellular vacuoles in these cells also. But then when you have these colloidal bodies, these are a result of filamentous degeneration. A civet cell technically is when you have a nucleus around it. A civet body is when it drops down into the dermis, forming a colloid body. It's called a civet body, but these terms are often used interchangeably by pathologists, though there is a slight technical differentiation. Okay. Now, not only do you see epidermal basal cell damage, in some interface dermatosis, when the inflammation is extending up to the top layers of epidermis. So interface obscuring dermatosis, example, in this case of pityriasis lichenoides, you're seeing this apoptotic cell, a result of filamentous degeneration, which is caused by apoptosis. And this is high up in the epidermis. Okay. Now, these are called high apoptotic keratinocytes, and this is very significant. And this helps us in making a diagnosis. Why? High apoptotic keratinocytes were described by Liboy to be seen in acute cytotoxic type of interface dermatoses caused by T-cell mediated cytotoxic damage. Okay. So these diseases, where you have high apoptotic keratinocytes, are caused by T cell mediated cytotoxic damage, causing damage to the epidermal keratinocytes high up in the epidermis. And these include the erythema multiforme T in spectrum of diseases, acute lupus erythematosus, the acute phase of pityriasis lichenoides, intense fixed drug eruptions, paraneoplastic pemphigus, because it also has an interface component, morbilliform drug eruptions, viral exanthems, and acute GVHD. Okay, so these are given as examples. These are associated with pan-epidermal ballooning degeneration, manifest as swollen vacuolated keratinocytes with clear cytoplasm. Okay, so in these examples, not only do you see ballooning degeneration, that is vacuolar degeneration, but you also see apoptotic keratinocytes leading to colloid bodies or cells that look like colloid bodies or civet bodies that are high up in the epidermis. Now, this is also ballooning degeneration of the keratinocytes. This is also ballooning degeneration. So these are high up in the epidermis, but some of them only have degenerate by filamentous degeneration. Majority of them have basically undergone vacuolar degeneration. Okay, so when there is filamentous degeneration, you see a civet body or a colloid body. Colloid body technically is when it's dropped down to the papillary dermis, you call it a colloid body. Otherwise, you call it a civet cell or civet body, but this is all semantic basically. Okay, so this is an example of erythema multiforme, where severe ballooning degeneration result in cell rupture and a lacy, feathery appearance in the epidermis. This is also called reticular alteration. Remember, such reticular alteration is also seen in severe spongiotic dermatosis. Okay, now this brings us to quiz number 4. So for those of you who want to still participate in the quiz, if you've joined late, the Kahoot game pin is 3502404. You can still join in. It just makes the lecture more fun. Okay, so the next question 4 of 16. Now, reticular degeneration is also seen in spongiotic dermatosis. So how does one differentiate this from interface dermatosis? Is it because spongiosis is absent in interface dermatosis? Or is it because basal cell degeneration is absent in spongiotic dermatosis? Is it because parakeratosis is absent in interface dermatosis? Is it because lymphocyte exocytosis is absent in interface dermatosis? What is the reason? How do you differentiate them? Excellent. We've got 53 participants this time. 37 of you have got it right, presumably because you've been listening to the lecture from the beginning. I told you for an interface dermatitis, basal cell degeneration is sine qua non. It is the primary most important factor to make a diagnosis. Okay. Without epidermal or basal cell degeneration, you cannot make the diagnosis. So spongiosis may be present in interface dermatosis. You may have parakeratosis. So the example of pityriasis lichenoides I shown earlier will have both spongiosis, parakeratosis, also has lymphocyte exocytosis. Okay. So even though all these three things are present, it is an interface dermatitis because it has epidermal basal cell degeneration, also high apoptotic keratinocytes, of course, in that case. All right. So leaderboard, Jalina is in number 1, followed by USS. Bhavit is in number 3, Pratyusha at number 4, and PM at number 5. Again, if you want prizes, please enter your full names. Okay. So going back to the lecture. Oh, we're now on to quiz number 5 as well. Okay. Let's move on to the next question. Quiz number 5. Let's see what it is. Vacuolar interface change is not usually seen in one of the following. Options: lichen sclerosis, dermatomyositis, lichen simplex chronicus, or Hansen's disease. Not usually seen. Right. Now, majority of you have got the wrong answer, in fact. Though Hansen's, so lichen sclerosis and dermatomyositis are classified as vacuolar interface dermatosis. So you can exclude both of them. So whoever has answered them is correct. You probably missed the earlier part of the lecture. So you only got 2 options, lichen simplex chronicus and Hansen's disease. Now, lichen simplex chronicus is a spongiotic dermatosis. It has nothing to do with the interface. Okay. So that is the answer, because Hansen's, in the tuberculosis spectrum, sometimes you can see vacuolar interface change. Okay. So that is the reason Hansen's is not the answer. Out of Lichen simplex chronicus and Hansen's, you have to choose. Of these, Hansen's can have vacuolar interface change, especially in the tuberculoid spectrum. Not in the lepromatous spectrum, but usually in the tuberculoid spectrum, especially in the borderline tuberculoid spectrum. Okay. So let's see what the leaderboard is looking like now. So we got Jelena still at the top, followed by USA Shreya. Savera Gupta, who's the winner for the last 3 quizzes, is now at number 4. She's slowly creeping up, and followed by Bhavit. So let's see how you do in the rest of the questions. We've still got 11 more questions out of 16. So this is the classical example of lichen planus. I think we all know this from textbooks for maybe first-year PGs if you don't know it. So this is a classical example of you have a band-like lymphocytic infiltrate hugging the epidermis, sawtoothing of the retiridges, hypergranulosis, which is often wedge-shaped, but you don't see the wedges often. Wedges correspond to the follicular units or the sweat glands when they go up, or the epidermal, dermatoglyphics. So they correspond to that, where you see wedge shape around it. It's not, the wedge shape doesn't correspond to anything else. So wherever we have a follicle, that's where the hypergranulus assumes a wedge shape, okay, or infundibulum. So don't think that wedge shape means something else. So often the stratum corneum is not usually, you have compaction of stratum corneum. You usually don't have parakeratosis there. So again, higher power showing vacuolar interface change, which can be present. Colloid bodies sometimes may be seen, as in this case, but sometimes you may not see colloid bodies. But it's fine. If the clinical is compatible, you still make a diagnosis of lichen planus. Now, here is a wedge-shaped hypergranulosis. I put this example to show that, and the Max Joseph space. Often Max Joseph does not contain any serum because it's an artifact. Okay. So classical lichen planus, these are the features. This brings us to quiz number 6. Okay, ready with your Kahoot. Quiz number 6 now. Which is true out of these 4 options? Wedge-shaped hypergranulosis specific to lichen planus. Hypergranulosis is usually absent in atrophic lichen planus. The diagnosis of lichen planus requires the presence of colloid bodies. The presence of parakeratosis rules out lichen planus. Which is true. Quite tricky questions here at this time, but a majority of you got it right. Hypergranulosis is usually absent in atrophic lichen planus. That is the right answer. Now, the second best answer, the presence of parakeratosis rules out lichen planus. I told you earlier, parakeratosis is usually absent, but the presence does not rule out lichen planus, especially in flexural areas. You may have secondary candle infection, or even otherwise, you may have a bit of spongiosis, or acral psoriasis may also be spongiotic sometimes. So when you have superadded spongiosis, parakeratosis may be present. That does not rule it out. Now, option number 3, the diagnosis of lichen planus requires the presence of colloid bodies. 2 of you have still answered that. I told you colloid bodies may not be present. I told that repeatedly. Wedge-shaped hypergranulosis definitely is not specific to lichen planus. Any condition with hypergranulosis, even lichen simplex chronicus, where you have hypergranulosis, the hypergranulosis may be wedge-shaped around the hair follicles and the sweat glands. Okay. Okay, let's see who's leading now. Janina is still reading now, followed by Pratyusha and USA, Shreya, and Prachi. Up 9 places, Rav, who is the highest climber. Well done. So let's move on to the next part of the lecture. So yes, this is an example of atrophic lichen planus, where you may not have hypergranulosis because there's so much atrophy. Hypergranulosis is simply because there is so much acanthosis. Okay, it's nothing related to the disease. So in atrophic lichen planus, because there's epidermal atrophy, the granular layer may be absent totally. That does not, that's not a factor. So this is a case of atrophic lichen planus. So how do we evaluate interface dermatosis? We've talked about lichen planus, we've talked about vacuolar interface change, we've talked about filamentous degeneration, we've talked about lichenoid dermatoses. So the evaluation of interface dermatoses depends on our understanding of the histopathological spectrum. And what does the what is the histopathological spectrum influenced by, or what determines the histopathological spectrum of these interface dermatoses? It's the intensity of inflammation. So lichenoid versus vacuolar, poly versus paucicellular interface dermatosis. Second, the primary immunological target, whether it's a basal keratinocytes in the epidermis, as in lichen planus, for example, whether it's a follicular unit that's involved in lichen planopilaris, or lichen planopogitis, where the eccrine duct is involved, or whether it's a melanocyte that's involved, for example, in vitiligo, where the melanocyte is a target. Then the rate of onset and progression of disease. This is the primary factor that influences, and also the time of biopsy and stage of evolution where you biopsied it. Okay, so if you biopsy a very late lesion of lichen planus, which is already regressed, you may not see any lichenoid interface change. You may only see an atrophic epidermis with some post-inflammatory changes. If you biopsy a very early stage of lichen sclerosis, you may in fact see a lichenoid dermatitis like lichen planus. So early stage of lichen sclerosis may in fact resemble lichen planus. Okay, so time of biopsy is very important. So therefore, this picture here could show you that the distinction between lichenoid and vacuolar is not so clear-cut. There's often an overlap depending on the stage of the lesion and the intensity of the inflammation. Okay, so what are the factors? Intensity, primary immunological target, rate of onset, time of biopsy, and also whether affection of special site. So for example, photoexposed sites are involved in lupus, scalp is involved in lichen planopilaris. So depending on site of biopsy, you can also make a diagnosis sometimes. Hypertrophic LP is usually common acral sites, and genital mucosa sites are often involved in lichen planus, LSA, for example. So based on the site of affection, you can often make a differential. You can also often narrow down the differential diagnosis. Okay, so what are the steps in the evaluation? Now, all my lectures, when you talk about evaluation, I follow Ackermann's algorithm, and Ackermann's algorithm clearly states we have to evaluate a slide always at low power first. Low power first, low power first. Look at low power, come to a differential diagnosis, whether it's lichenoid, spongiotic, psoriatic, granulomatous, whatever it is, and then go on to high power and confirm your diagnosis. Okay, so on low power, we determine whether it's predominantly lichenoid or vacuolar, cell poor or cell rich. Then we look at the distribution of the infiltrate at the interface first, whether it's touching the base membrane, as in lichenoid spectrum, early lichen sclerosis, lichen planus, I told you, or obscuring the dermal-epidermal junction, as in erythema multiforme, fixed drug eruption, pleva, etc. And then you look at the distribution of infiltrate in the dermis. Okay, so distribution of infiltrate in the dermis, is it just superficial? And these are your differentials: lichen planus, lichen sclerosis, vitiligo, fixed drug eruption. It's only the superficial papillary dermis that's involved. Is it superficial and deep? Superficial and deep, then your differential are lupus, drug reactions, morphia primarily. Vitreous lichen doesn't go that deep. It's usually up to the upper epidermis to mid dermis. Okay, but lupus, drugs, and morphia can affect both the superficial and deep dermis. Is it just perifollicular? You've got lichen planopilaris, lichen striatus, DLE sometimes, periacrine, lichen planopogitis, or is a focal single papilla affected? Then you've got your diagnosis of lichenitis, which is a favorite, easy to remember diagnosis in the lichenoid spectrum. Rarely, however, remember that papillary GA, papillary sarcoid, and lichen sclerophosorum can also trick us into believing that this is lichenitis. I won't go into the details in this particular lecture. We'll talk about this in the granulomatous lecture. So this is an example of lichen planus, follicular lichen planus, where only the follicles are affected. This is lichenitis, easy diagnosis. Okay, so what about evaluation? Once you may narrow down your differentials on low power, then you go to higher power to confirm your diagnosis. So what are the features that help us make a diagnosis on higher power? Stratum corneum. So first, in most interface dermatosis, apart from EM, SJST in spectrum, you see either compact hyperkeratosis or parakeratosis. If you're seeing ortho, meaning basket weave type hyperkeratosis or basket weave type stratum corneum, the diagnosis is erythema multiforme spectrum. The reason is basket weave is the normal, appearance of the stratum corneum. Okay. In erythema multiforme, SJS and TEN, because the insult is acute, the stratum corneum has not changed. The acuteness of the process has not given enough time for the stratum corneum to either become compact or parakeratotic. So the normal basket weave pattern is retained. And this is a clue to the diagnosis of erythema multiforme apart from necrosis of the epidermis. Okay. Now, parakeratosis is usually associated with spongiotic disorders. When you have spongiosis associated with interface change, and the classical examples are pityriasis lichenoides and lichen sclerosus. Okay, you often have parakeratosis, and this is a clue to these particular dermatoses. So this is the example of erythema multiforme I showed you earlier. This is the basket weave orthokeratosis that is preserved, and you're seeing here full thickness epidermal. You're seeing necrosis here. I showed you this example of reticular alteration, which is confluent ballooning degeneration, but you're seeing necrosis here as well. And the diagnosis is pretty clear-cut in this case. Okay. So this is another example of epidermal erythema multiforme, where you're seeing confluent epidermal necrosis without much in the way of ballooning degeneration. But then you see the preserved stratum corneum, the basket weave pattern, and here again your diagnosis is pretty clear. So look at the stratum corneum if you're trying to make a diagnosis of erythema multiforme. Then what are the epidermal features? Then you got the epidermal thickness. If it's acanthotic, the diagnosis is usually lichen planus. Okay. If it's very acanthotic, then if there is lichen simplex cornicus changes associated with lichen planus, often in the acral areas, the diagnosis is hypertrophic lichen planus. Usually in the other interface dermatosis, unless it's a chronic case of DLE, sometimes you may have hypertrophic DLE. Usually acanthosis associated with lichenoid dermatosis is lichen planus. Atrophy, so in the other interface dermatosis, the epidermis may be normal, but atrophy may be present both in acute phases as well as chronic phases. In the acute phase, because of intense inflammation, the epidermis may become atrophic totally because it's eaten up. Or in chronic inflammation associated with squamatization. I'll explain what squamatization is, but essentially it means that the basal cells are destroyed. Where do keratinocytes grow from? They grow from the basal cells up, right? So when the basal layer is destroyed, you don't have enough of reservoir to produce enough epidermal cells. So therefore, there's atrophy. And here you have, so therefore, in chronic atrophic lichen planus, DLE, lichen sclerosus, etc., where the basal layer is totally destroyed, or there, in those cases, you may have epidermal atrophy. So this is an example of hypertrophic lichen planus. Of sometimes a pseudoepitheliomatous hyperplasia is so prominent, you can mistake it for squamous cell carcinoma. But then squamous cell carcinoma may also arise in hypertrophic LP, and this makes the job of the pathologist very tricky sometimes. I won't go into the differentiation right now. So squamatization of the basal layer, I told you, where the basal layer is destroyed, it looks as if the spinous layer is sitting on the papillary dermis directly. There's no basal layer. So this is called squamatization of the basal layer. It's the clue to the diagnosis of lichenoid dermatosis. See, sometimes in late phases of lichen planus, I told you, the epidermis is just atrophic. Okay, in the post-inflammatory phase, the epidermis is just atrophic. Here you're seeing some squamatization, but there's no hypergranulosis. The epidermis is just atrophic. You're seeing some colloid bodies, some melanin incontinence. So this is called the post-inflammatory phase. Here you cannot make a specific diagnosis, but you can tell that there has been a lichenoid interface change before. Okay. And in some cases, this is an example of lichen planus pigmentosus in the post-inflammatory phase. The epidermis is atrophic. You can make it out. There are no reticages. So this is called effacement of the reticages. Okay. There is some epidermal atrophy. But then, seeing no inflammation, so you cannot make a specific diagnosis, but you're seeing pigment incontinence, so you can say compatible with lichen planus pigmentosis, if that is the clinical history. So, we've talked about the stratum corneum. We talked about the acanthosis, the thickness of the epidermis. The other feature that you look at in the epidermis is the extent of epidermal involvement. If only the basal layer is involved, you've got these differentials. Chronic GVHD, vitiligo, lichen sclerosus, discoid lupus, dermatomyositis, or lichen planus. So none of these involve the upper layers of the epidermis. If the entire epidermis or the higher layers of the epidermis is involved, we are dealing with the acute cytotoxic diseases that Leboy has described, remember? And so those diseases come under this spectrum where the entire epidermis is involved. So depending on the affection of the epidermal layer, so you can also say these are post-inflammatory and these are poly-inflammatory diseases. But then lichen planus is also poly-inflammatory, but it involves only the basal layer. The rest of the diseases are post-inflammatory. These are all diseases associated with intense inflammation usually. Okay. So this is a typical example of pityriasis lichenoides. I showed you the higher power earlier. This is the lower power, often associated with spongiosis, confluent parakeratosis, some amount of epidermal atrophy, interface dermatosis, which obscures the interface, as you can see here. Sometimes you may see melanin incontinence. Colloid bodies are not usually seen in these spectrum of diseases usually. It's usually only in lichen planus we see colloid bodies. They may be seen rarely in other diseases, but it's often not the case, at least in my experience. You don't see colloid bodies usually in the other vacuolar interface dermatosis. Technically, this is a vacuolar interface dermatitis because you don't see filamentous degeneration. You don't see colloid bodies in this entity, i.e. pleva. Okay. I don't usually report something as pleva or PLC because even in pityriasis lichenoides chronica, if you biopsy the earliest lesion, it will have features of pleva. So pleva is acuta. Pityriasis lichenoides at varioliform is acuta. So in the acute phase of acute lesion of pityriasis lichenoides, you may see acute changes. If you biopsy a late lesion of pleva, you will see chronic changes. So this distinction is really clinical rather than histological. Okay, this brings us to quiz number 7. But then I'll have to show you a picture before we go to the quiz. The following picture will be described. Okay. So you may or may not have seen such a picture before, but what I'm trying to show you is this particular apoptotic keratinocyte surrounded by a few lymphocytes. Okay. So when one apoptotic keratinocyte, degenerate keratinocyte, is surrounded by 2 or more lymphocytes, okay, there is a particular name to it. Okay. And this is what the next quiz is about. Let's go on to quiz number 7. This feature is typically described in, but not specific to which of the following? Only one answer. It's typically described in, but not specific to one of the following diseases: erythema multiforme, acute GVHD, drug reactions, or radiation dermatitis. Okay, so majority of you have got the answer right. This is called satellite cell necrosis, typically described in acute GVHD, though it may be seen in any number of diseases, including erythema multiforme, drug reaction, radiation dermatitis, but it is not specific. But originally it was described in this condition. Okay, so let's see what the leaderboard looks like. Savera Gupta is back to number 2. Namita Tumbal is number 1. Jelena is down to number 3. Up 13 places, Arvind, who's the highest climber. Shubham and Pratyusha have gone down a little. Okay. No bother, you've still got a number of questions to go. So quiz number 7, I think this is quiz number 7, right? Okay. So satellite cell necrosis, also called lymphocyte-associated apoptosis, basically is an apoptotic keratinocyte surrounded by 2 or more lymphocytes. Prototype is GVHD, but not specific. Also observed in a number of other entities. Okay. Quiz number 8. See the following picture. So this is the picture I want you to see. I'm not going to describe it. What I want to show you is pretty obvious. Okay. So I'll go on to the Kahoot slide. You've had enough time to look at the slide now, at the picture. So quiz number 8 of 16, halfway through. This feature is not seen in DLE, lichen sclerosis, dermatomyositis, or chronic GVHD. The feature I've highlighted in the picture is not seen in which one of the conditions here? Right, only 12 of you have got the answer correct. So the feature I want to show you was thickened basement membrane. Okay, let me go back to the slide. It can't get any thicker than this. This is the thickened basement membrane. That is what I'm showing you here. And this feature is not seen in chronic GVHD usually. The typical examples of thickened basement membrane are essentially DLE and dermatomyositis, but also lichen sclerosis. You can see a thickened basement membrane sometimes. Now, thickened basement membrane is not specific to any entity, to be honest. Okay. But basement membrane is usually destroyed in the majority of other entities where there is interface obscuring dermatosis. For example, in the acute cytotoxic type of diseases, there is interface destruction, basement membrane destruction. Even in lichen planus, there is basement membrane destruction. Chronic GVHD usually presents with lichen planus-like lesions. Okay, so usually the basement membrane is destroyed there. So that is definitely not the answer. That can be the answer. So I mean that in that particular entity, basement membrane cannot be present. So that is the answer in this particular case. So answer is chronic GVHD. In all the other entities, basement membrane is thickened. So let's see who's leading. Savera Gupta is now back to the top of the leaderboard. Well done again. Pratyusha is number 2. Namita is number 3. LKG. Whoever that is, please expand your name. Otherwise, not getting a prize. Prachi is number 5. Okay. So, summary of epidermal changes. If you're seeing epidermal necrosis, frank epidermal necrosis, it's EM or TEN, especially when associated with basket weave orthokeratosis. Satellite cell necrosis, GVHD, drugs, EM. Pseudoepitheliomatous hyperplasia, LPH. Atrophic epidermis, LSA, LE, atrophic LP. Parakeratosis, spongiosis, I told you, pityriasis lichenoides and lichen spiratus spectrum. Especially if you've got periappendigeal or deeper infiltrate, then lichen striatus is more likely. So that's how you differentiate these two entities. If the basement membrane is thickened with or follicular plugging, then you've got DLE. If there's no follicular plugging, then you may think of dermatomyositis or lichen sclerosis. Lichen sclerosis, of course, you've got sclerosis in the dermis. Okay, now this brings us to the dermal changes. Dermal changes, the first and most important thing is pigment incontinence. You can see this quite nicely in the case of lichen planus pigmentosis. Lichen planus pigmentosis, usually I would say it's a variant of atrophic lichen planus because the histology is pretty much similar. Clinically, it differs because atrophic lichen planus may produce papules sometimes. Lichen planus pigmentosis has a typical macular appearance. Okay. Now, this brings us to quiz number 9. So, let's see what quiz number 9 has in store. So, what's the quiz? Pigment incontinence is far greater in interface dermatosis because A, stimulation of melanogenesis, B, defective transfer of melanin, C, keratinocyte destruction, D, all of the above. So pigment incontinence may be present in a number of dermatoses, including spongiotic dermatosis. It is not specific. But why is it more in interface dermatosis? The mechanisms are not in pigment incontinence. The answer is all of the above. Most of the cases where pigment incontinence is present in interface dermatosis, not only is there stimulation of melanogenesis because the inflammation, often these conditions are pigmentary disorders. If you look at either lichen planus or if you look at lupus, often there is hyperpigmentation. Of course, in late phases when there's atrophy, you may have hypopigmentation, but in the initial phases, there is stimulation of melanogenesis. And also, because of the intense inflammation, the melanosomes are not transferred onto the keratinocytes. So there is defective transfer of melanin and also, of course, associated with keratin destruction. These are the 3 mechanisms that cause pigment incontinence in interface dermatosis. Okay, so the answer is in fact all of the above. Keratinocyte destruction, I told you, may be present in other entities, though it's not vacuolar or it's not apoptotic. That, yes, keratinocyte destruction is present usually in interface, but it is not the only mechanism. All the above mechanisms contribute to pigment incontinence in interface dermatosis. The answer is all the above. So let's see who got the correct answer. Savera Gupta is leading still, followed by N. Please expand your name. Pratyusha, Namita, and LKG. Okay. So what are the other dermal features that we see? Now, sometimes you may only see vacuolar interface change, which is subtle. associated with solar elastosis and ectatic capillaries. So you see vascular ectasia, telangiectasia, not so prominent here, but you can make it out here. Solar elastosis and vacuolar interface change. This is an example of poikiloderma. Okay. Sclerosis, typical example, atrophy in the initial phases, in the inflammatory phase, it can appear lichenoid. So this is an example of lichen sclerosis. Often you also see dilated blood vessels in this entity. Okay. Extravasation of RBC may or may not have, some vacuolar interface change in this section, often associated with a dense lymphocytic cuffing around the vessels. This is an example of pigmented purpuric dermatosis. Lichen aureus is a typical example of this entity. Okay, where you may see extravasation of RBC, perivascular cuffing of lymphocytes, and sometimes a interface dermatosis. When mucin is very prominent, associated with an interface dermatosis, your diagnosis is lichen, is a diagnosis of lupus erythematosus. So look at mucin. These are the blue fibrillary stuff in the dermis is mucin. So if you're seeing mucin in association with superficial and deep perivascular dermatitis, think about lupus. So these are clues in the dermis. So dermal changes summary: pigment incontinence, FDE, LPP, lichen planus pigmentosis, telangiectasia, solar elastosis, poikilodermas, mucin, lupus, sclerosis, lichen sclerosis, or morphia, capillaritis, lichenoid purpura, panicleitis, which I haven't shown you pictures of, lupus, granulomatous changes, lichen nitidus, lichenoid granulomatous dermatitis, sarcoid, Hansen's. We'll discuss that in the granulomatous dermatosis lecture. Okay. Quiz number 10, see the following two pictures. I think the rest of the cases are just quiz. I'll be discussing them in the form of quizzes. We've got 6 more quizzes to go and 6 more cases to go. So see the following two pictures. This is picture 1 of 2. I'm not going to describe it in great detail. We've already discussed these cases. I've already discussed these diagnoses. So this is just a revision. So look at the features here in this particular case. Think of all the steps in evaluation, epidermal changes, dermal changes we discussed. Now, same case, this is a low power image. And I've shown you the description. There is a mound of parakeratosis, nodule of lymphocytes and histiocytes, perivascular lymphocytic infiltrate, and perifollicular lymphocytic infiltrate. Okay. So you've got the higher power shown to you first, and then the low power. Low power, I've described the clinical histological features already. Okay. So what is the diagnosis? I think you've had enough time. So here are your options. What is the likely diagnosis? Your options are lichen striatus, pityriasis lichenoides, lupus erythematosus, or acute GVHD. Hmm. 20 of you have selected pityriasis lichenoides. Remember, I told you affection of the follicle is a clue. Deep, especially in deep dermis, is a clue to the diagnosis or differentiation from lichen striatus. Now, in this particular case, I've shown you there are only 2 differentials, to be honest. When you see in this picture, this is an interface obscuring dermatosis with parakeratosis and some spongiosis. When you're seeing spongiosis, you can see the desmosomes here. With parakeratosis, you mainly got 2 differentials. One is lichen striatus and one is pleva. Pityriasis lichenoides. The differentiating factor is a deep follicle involvement. When the deep follicle is involved, it is lichen striatus. Okay, I hope it's easy to understand now. It's good to make a mistake, don't worry. I hope you won't repeat the mistake again, and the differentiation is now ingrained into your mind pretty well. Scoreboard, Pratyusha is now on top, followed by Savera Gupta, Namita, Prachi, and Pavitra now. Well done, all of you. Now we've got, I think, 5 more questions to go. So next case, quiz number 11, see the following picture. It's a single picture. Which of the following diagnoses unlikely based on this histology? So there are 4 options that are going to be presented to you in the Kahoot app. Which of the diagnosis is unlikely? So evaluate this image, single image. Remember what we discussed: epidermal changes, dermal changes, interface changes, lichenoid, vacuolar, paucicellular, or polycellular. Remember all these. And what diagnosis is unlikely based on this histology? So here are your options: dermatomyositis, lichenoid keratosis, lichen planus, or drug eruption. All these are revision. I've already discussed these multiple times in multiple slides. The answer is indeed lichenoid dermatomyositis, because all of the others are lichenoid dermatosis. Lichenoid keratosis, lichen planus, drug eruption can be lichenoid. Dermatomyositis is usually vacuolar interface dermatosis. I told you it's a paucicellular. I have discussed that in the earlier slides. So the answer is dermatomyositis. 15 of you have got it right. So Savira Gupta is down to number 2. Prachi is up to down to number 3. Prachi is up to number 2. Well done. Pratyusha is reading at number 1. Well done. Followed by now Namita at number 4 and Logamurthy. Up 12 places, Vikas, who is the highest climber. Well done. So let's see the next question. Question number 12. So we've got 4 more cases left. See the following picture. So this is a 3-month history of a single itchy 0.5 centimeter warty lesion on the forehead of a 25-year-old male. What is the diagnosis? Okay. So look at this histological image. I'll give you 10 more seconds. Make a presumptive differential diagnosis based on the epidermal and dermal changes we've discussed. If I've not shown you anything deep, it means there's nothing deep. So you can presume so. 3-month history, single lesion, itchy on the forehead of a 25-year-old male. Okay. Right. Let's go to Kahoot. Quiz number 12. What is your diagnosis? Okay. DLE, lichen planus, lichenoid keratosis, or seborrheic keratosis? Excellent. A lot of you have got the correct answer. 28 people. So the diagnosis is indeed lichenoid keratosis. Now the biopsy, the histology I showed you earlier is typical of lichen planus. Okay, but when it's a single lesion, don't ever make a diagnosis, especially in the face. Who would make a diagnosis of lichen planus a single lesion? You cannot make a diagnosis. So when you have a histology resembling lichen planus, but it's a single lesion and you don't have any other etiology, it's called lichenoid keratosis. Okay. So lichenoid keratosis is, I'll explain that in the next case, because we've got another case and I explained why it is lichenoid keratosis. It's not DLE because it's a single lesion again, 0.5 centimeter, unlikely. No basement membrane thickening I've shown you. It's not DLE. Seborrheic keratosis, there are no features suggest seborrheic keratosis, to be honest. Okay. So Pratyusha is down to number 3, Prachi at number 1, Savera at number 2, Logamurthy and Namita at number 4 and 5 now. 10 places up is Pujit, who's the highest climber. Well done all. So we've got 3 more cases to go. Kahoot quiz number 3. Look at the following 4 pictures. So this is a 76-year-old man with a pigmented patch in the face. Okay. What is your diagnosis? This is picture 1 of 4. This is a silhouette. Okay, so this is part of the pigmented patch. You can see here. You can see the pigmentation quite nicely. Higher power, showing you something going on here. Still higher power of the same, showing something going on here. And still higher power, showing something going on here. Okay, so these are 4 images. 76-year-old male with a pigmented patch on the face. Okay, what is the diagnosis? We'll go back so that you can see the lower part once more. 1, 2, 3, and 4. Okay, here are your options. Question 13 of 16. We've got 3 more to go, I think 14, 15, 16. Okay. Is it the solar lentigo with lichenoid change? Is it lichen planus pigmentosis? Is it lichenoid keratosis? Or is it Reals melanosis? Excellent. Well done. The answer is indeed solar lentigo with lichenoid change. Now, the difference between lichenoid keratosis and solar lentigo with lichenoid change, lichenoid keratosis is presumed to be either a basal cell papilloma, i.e. seborrheic keratosis, or a solar lentigo, or even a superficial BC which is regressed. Any epidermal lesion which in the process of regressing induces a lichenoid change. But the when the precursor lesion is no longer visible, it's called lichenoid keratosis. It might even be a wart. It could be anything. But the precursor lesion should no longer be visible. It should look like lichen planus histology. You should not see the precursor lesion. When the precursor lesion is visible, you make the diagnosis of precursor lesion. Don't call it a lichenoid keratosis. This is a typical solar lentigo. So sometimes you may see a basal cell carcinoma with lichenoid change. You don't call it lichenoid keratosis. You call it a basal cell carcinoma. Okay. So you call it a lichenoid. You can call it a lichenoid BCC. You can call it a lichenoid solar lentigo. Okay. But you still have to make diagnosis of the original. You still have to pick out the original diagnosis. It's not lichen planus pigmentosis. It's not like Reals melanosis. Okay, let's see who's got the correct answer. So Prachi is still on top, followed by Logamurthy, Pavitra, Savera Gupta, and Shreya. 3 players just hit an answer streak of 3. Well done. So let's move on to the next question. Question number 14. See the following 4 pictures. This is picture number 1. It should be finishing soon. Another 3 more cases after this. Sorry, 2 more cases after this. Low power, higher power image of the deep dermis. You can see the eccrine glands here. You can see a nerve bundle here. Eccrine glands, nerve bundle. Higher power of the epidermis. Question, picture 4 of 4 showing the epidermis again. Okay. So you should have got the diagnosis by now. We've already discussed this case umpteen times, or this diagnosis rather umpteen times. So what is the diagnosis? Option A, DLE. Option B, GVHD. Option C, Hansen's. Option 4, lichen sclerosis. Excellent. Most of you have got it right. The answer is DLE, superficial and deep perivascular, perifollicular infiltrate. Sometimes you can have perineural as well. That doesn't discount the diagnosis. Follicular plugging. And the last picture I showed you, basal membrane thickening. That's the final, nail in the coffin. Hansen's is a closed differential because of the perineural infiltrate, but it is not really. You're not seeing any curvilinear granulomas. It's not granulomatous at all to call it Hansen's. Lichen sclerosis, you could think of it, but then, you're not seeing much in the way of papillodermal sclerosis. You're seeing some scarring, but it's not really papillodermal sclerosis, okay? So the answer is GVHD. Let's see. Sorry, the answer is DLE. Let's see who has got who's leading. Prachi is leading with 7,000 points, 7,462, followed by Logamurthy. Savera, Namita, and Pratisha is now back onto the top 5 of the leaderboard. 3 players have reached an answer streak of 4. Well done. So we've got 2 more questions to go. Question number 15. See the following picture. Single picture. What is the diagnosis? These are all revisions. Hopefully, by the end of the lecture, you can diagnose all interface dermatosis very easily. Okay. Remember how we evaluate. Lichenoid, vacuolar, interface changes, filamentous degeneration, vacuolar degeneration, Is it the basal layer only involved? Is the epidermis also involved? Other features in the epidermis? Okay. So what is the diagnosis? I think we've had enough of this picture. Erythema multiforme, SCLE, pityriasis lichenoides, or lichen aureus. All of you should get this right. I am disappointed because we've discussed this just a case ago when we're discussing lichen scleritis. There is parakeratosis. I think a lot of you were fooled by the basket weave orthokeratosis, but that is underpinned by a layer of parakeratosis. You see the parakeratosis which is pushing out the basket weave. This parakeratosis, along with an infiltrate which is obstruing the interface, high apoptotic keratinocyte. This is the same picture. In fact, the low power image of the high apoptotic keratinocyte I showed you earlier. Some amount of spongiosis here. You can see some desmosomes. There is no epidermal necrosis. Okay. This is pityriasis lichenoides. I think you were put off by the basket weave orthokeratosis, but there is parakeratosis. Don't forget that. Just because you have basket weave, don't make a diagnosis of erythema multiforme. You should see, you're seeing parakeratosis here. So how can you just look at the basket weave and make a diagnosis of erythema multiforme? You can't. So the correct answer is pityriasis lichenoides. So let's see what the leaderboard is looking like. Pratisha is up from 5 to 4. Savira Gupta, Logamurthy, and Prachi retain the positions. Logamurthy has the highest answer streak of 6. Well done. So let's go on to the last question. Let's see how you guys do. Question number 16, we've got 3 pictures. Okay. Picture 1 of 3. This is the histological appearance. I'm not going to say much about this picture because it will give away the diagnosis. This is picture 2 of 3. I think picture 3 of 3 would be most important. This is picture 3 of 3. Okay, let me go back to picture 1 of 3 because it's the last question anyway. Low power. This is a higher power image, 40x of one area and 40x of another area. Okay. You should be able to make a diagnosis of low power itself, to be honest. Okay. All right. Let's go on to the last question. Best of luck to all of you. Question number 16 of 16. What is the diagnosis? Your options are pityriasis lichenoides, erythema multiforme, lupus erythematosus, or mycosis fungoides. So we've got a 15 consistent people who are getting consistent, the right answer consistently. I see the number 15 frequently. The answer is indeed mycosis fungoides. Now, technically, it is an interface dermatitis because you see some keratinocyte is a degeneration, but all these vacuolated cells are in fact lymphocytes. Okay. All of these are lymphocytes. How do you make the differentiation? Keratinocytes have a larger nucleus. Okay. And when they are degenerate, they become pycnotic. So this is a pycnotic nucleus, for example. It becomes pushed to the side and hyperchromatic. This is a lymphocyte with a perinuclear halo. Okay, these are lymphocytes with perinuclear halos. These are all lymphocytes with perinuclear halos, which are all clubbed together. This is a Portier's abscess. Okay. So and you see here Indian file lining of vacuolated lymphocytes with a perinuclear halo. You don't see this normally in a true interface dermatitis, and there's hardly any inflammation, very little inflammation in the dermis to account for this amount of vacuolar interface change. Here there is inflammation, but where is the inflammation here? Why would these cells become vacuolated if they're keratinocytes? Why would there be confluent vacuolation? These are all lymphocytes which are lining up around the basement membrane. Okay, so this is mycosis fungoides. Well done, all of you. So let's see what I think before I wind up, let me just see what the concluding slides are. Yeah. So almost my entire lecture is based, and I've summarized my understanding of interface dermatosis in this paper. For those of you who have not read it, it is in the Indian Journal of Dermatopathology and Diagnostic Dermatology, published in 2019. So you can go through it. All the pictures are also there. So I've summarized all my understanding of interface dermatitis there. And yeah, thank you very much. There is a Dermatopathology WhatsApp group. A lot of you are already in the group, but if you're interested, please feel free to message me on this number. Okay, so let's look at the leaderboard. Who's the final winner? So at number 3 is Savera Gupta, who is the winner for all last previous quizzes. Well done. Followed by Prachi at number 2, and number 1 is Logamurthy. Well done, Logamurthy, for being number 1. Please message me, or Logamurthy and Prachi. Logamurthy, sorry, is the winner. So yes, Logamurthy, please message me your email address and phone number, etc., because you'll be given free registration at the DSI annual conference, which is actually coming up in 2 weeks' time if you want to attend. And you'll be given 2 textbooks. One is a dermatopathology textbook and one is a clinical dermatology textbook. So that's the incentive for all the winners. Well done for all those of you who have participated. Now let's see if there are any quick questions that we need to answer in the chat box. Could you please display the dermal summary slide? You'll have the lecture, the video lecture. I'll share it in the dermatopathology group and also on my WhatsApp. So we'll repeat it so you can have a look at the lecture again for those of you who are interested. Somebody has just written ochronosis, pityriasis, lichenoides, and lichenoid keratosis. I think we've discussed everything. If you have any questions burning questions that you still want to ask, please feel free to message me privately on WhatsApp. Okay, so hope you enjoyed the quiz. I would like to thank DSI and the IADVL Academy once again. I don't know if Dr. Lalit sir is online and he wants to say a few words. Lalit sir, are you there? Probably not. Tech team, please note down Dr. Logamurthy's email and phone number. Is put in the chat box. So anything from Glowderma you want to say before we conclude?
Thank you so much, sir. I guess Yogeshwar sir is not here, but thank you so much. This is a fruitful lecture, and I will display all the winners, Logomurthy, to the certificate and book.
Yeah, somebody asked for the Dermpath WhatsApp, so I'll just put my WhatsApp number in the chat box. Just a second. So those of you who want to join the WhatsApp group, so that's my number. You can message me personally, and I'll add you to the Dermpath WhatsApp group where we discuss interesting cases and also some basic Dermpath classical cases I'll be posting from time to time. And there are others in the group as well who are seniors, dermatopathology experts who will be discussing. So it will be nice for you to listen on to the discussion. So please feel free to join in if you've not already joined in the group. Thank you very much, all of you, and hope to see you at the next lecture. Thank you.
Thank you, sir.
Thank you. Thank you.